want as few people as possible to have unnecessary thyroid surgeries.
Well, I don't think there's any better way to close this out. You're listening to Save Your Thyroid with Jennifer Holcomb. This is the podcast where we challenge the status quo of thyroid treatment and advocate for the preservation of your most vital metabolic engine. For a long time, thyroid care followed a very predictable one-way street. If you had a nodule that caused symptoms, you were often told your only real exit was a thyroidectomy. It was a trade-off. You lose the symptoms, but you also lose the gland, the hormones, and a piece of your autonomy. For many, the question wasn't if you would have surgery, but when. But today, we're talking about a new frontier. We're moving away from the era of management into the era of intervention. We're seeing a new breed of physicians, interventional endocrinologists, who are refusing to accept that surgery is the only answer. They are utilizing precision technology like radiofrequency ablation to treat the problem at its source while keeping the patient whole. Joining me today to discuss this shift is someone who isn't just practicing this technology, he's building a new home for it. Dr. Ian Orozco is a board-certified endocrinologist based in Provo, Utah, whose reputation for excellence in RFA has made him a beacon for patients throughout the Intermountain West. Dr. Orozco has recently taken a bold step in his career by moving to the Thyroid Institute of Utah, the oldest and most established thyroid-only practice in Utah. By moving into private practice, he has created a specialized environment where the focus is entirely on the modern patient, someone who's informed, proactive, and looking for alternatives to the operating room. He's a physician entrepreneur who is quite literally redefining what it means to be a thyroid specialist in the 21st century. Dr. Orozco, welcome to the show.
Thank you for having me. It's great to be here.
It is always nice to talk with you. We've known each other a few years now, and this is your, I believe, your second time on the podcast. So thanks for coming back.
Absolutely. And thanks for having me.
I'm excited to talk about this move that you've made. But let's start with the fact that many of the listeners who are returning viewers of this podcast may know of you from your previous work in the region. So why don't you share a little bit of the history, your history leading up to the transition and now the history of the Thyroid Institute of Utah and what inspired you to branch out in this way?
So I've been doing RFA now for about 5 years, and I've wanted to make it a specialized, single focus. This is what we do. And on a personal note, I don't really want to work for anybody. I've kind of been that way for a while. But it gives me the freedom to tailor the practice, everything from the initial contact to, I have a thyroid problem or I have a thyroid nodule, and from the point of contact of contacting the office to be seen through the initial consultation to the day of RFA, if that procedure is indicated, to sort of the follow-up care that I have control of all aspects of it, and that I can hire the right people to make sure that it's the best experience possible, that we can make sure that it's the best experience possible from, start to finish to, for folks who are familiar with RFA, when you sort of have the surveillance imaging and care afterwards to see the results of the procedure. It just provides me the ability to be more agile, to sort of better change things and processes to better fit an individual patient, and to just overall make it a better patient experience.
That's great. Tell us about the practice that you've become a part of.
Yeah, so the Thyroid Institute is actually a relatively old practice, although I've taken over it now and sort of refocused it to specifically thyroid care. It was actually started over a decade ago by some ENT surgeons. And at that time, RFA, of course, was not available in the United States. It was in other countries. But even then, and in instances for folks who have thyroid problems for where RFA, they're not a candidate for RFA. Working very closely with surgeons as an endocrinologist in terms of our ultrasound skills set for many of us who are interventional endocrinologists, and thyroid biopsies, and just preparing folks for surgery who require surgery, having that very close relationship with the surgical group really makes the patient care better. Mm-hmm. I carry that on today. I still work very closely with the surgeons who previously, owned the practice. And so when you have cases where, clearly surgery is the direction that folks need to go, being able to have that communication and dialogue with them around surgery, after surgery is very, very beneficial. But as RFA has sort of gained traction and other non-surgical techniques, the need to send patients to surgery is becoming less and less and less and less. And so you can imagine if you're a surgical group that owns a thyroid practice who is really no longer working as frequently in close concert with you, that becomes significantly less attractive for them to sort of hold on to as part of their, it was really a multi-specialty group at the time. So now we're completely split off. So we're entirely different entities, but we have a very cordial, friendly working relationship. I still share some office space with them. And so, like I said, when I have patients who require surgery, which still is required for cases, it's very easy for me to sort of transfer their care to them and then for them to come back to me for the follow-up care afterwards.
I think that's incredible. That dialogue and that collaboration between specialties, I feel like is so critically important, particularly in thyroid, because like you said, we do have patients who need surgery. The reality is there are always going to be patients who need surgery, even though the indications for non-surgical technologies are expanding more and more every day. We're seeing some people are using RFA to treat parathyroids, and thyroid cancer indications are expanding, and before we know it, we'll be seeing all kinds of things that we couldn't have even dreamed of 5 years ago, 7 years ago when this became FDA cleared in the US. So I think that collaboration between specialties is only going to increase even as we do see surgeries decreasing. And I honestly, kind of just as a side note, I think it'll be really cool when somebody takes on the task of actually finding out how many less surgeries have been done since the inception of non-surgical, particularly RFA in the US treatment for thyroid nodules. I would just love to see that data because it would be really interesting to see the downward trend or how downward of a trend really was it.
Mm.
So if you ever find out about that, if you find out someone's doing that research, let me know because I've been just waiting for a while now to see someone do that.
Yeah, that's a great question, and we don't have a lot of data on that. And I think the challenge on that is that I still think infancy is probably not quite the right word, but certainly not adolescent. I mean, it's so new for it. I was at a conference last year, and I talked to a guy who was the only one in the entire state of Arkansas that does RFA,
Right.
right? And so it's just still widely not available.
Right.
And I'm actually still shocked sometimes when it's not indicated. I had a referral just a month or so ago, and, a very educated patient who was familiar with RFA. And, she was in Boston, right, for school and seen at one of the big institutions there, who I won't name. And, autonomously functioning thyroid nodule, benign biopsy, reasonably controlled on medication. We discussed, in a previous podcast in terms of size and perfect location, great size. Everything says this is an RFA case.
Yeah.
No one even brought it up. No interest in doing it. She was basically told radiation or surgery. And then she moved, out here to Utah and came and see me. And I'm literally reading through her chart going, please tell me she hasn't had surgery. Please tell me she hasn't had surgery. Please tell me she hasn't had surgery. And so even in, Boston is no slouch, right? I mean, you've got
Right.
excellent medical centers there. You have excellent endocrinologists there. You have excellent endocrine surgeons there. And just not something that, crossed the radar for
Yeah.
that particular individual. So, there are states where it's just not available. And then I think that there's states where, there's places where it's available and it's just still supremely underutilized. Now her case was, and I, reading between the lines, I'm not sure. She didn't have the nicest looking nodule. So, traditionally we do one biopsy before doing RFA on a hot nodule, an autonomously functioning nodule. I did do a second on hers, just kind of reading between the lines, was there some hesitancy there for that reason? And just to sort of do it under my own care to make sure that she has the green light
Absolutely.
to do it. But at the same time, just the fact that it's, 2026 and, the topic wasn't even really broached. And you're just
Yeah.
kind of like, really?
Yeah.
And so that happens, and that can happen, anywhere.
Absolutely.
Part of I have a little sort of a joke on that one, and not to offend my surgical colleagues that do RFA, but, I always kind of say, if you want to have thyroid surgery, go talk to a thyroid surgeon. And, and I think in her instance, it may have been who was, managing her care who just did not do it. And I've had plenty of consults too, where I'm sort of the second opinion. They told me this nodule is too big, or it can't be done because of X, Y, or Z. And most of the time, that is not accurate. Now, whether or not it'll require more than one session or whether or not there's a specific technical issue with that nodule, that's a different question. And then that always also sort of comes down to, what is the patient's motivation? If you have
Okay.
one of those big, large nodules that's going below the clavicle, everyone who does this knows if you want to really treat a doll, it's going to be more than one session. But that's patient dependent too, right?
Mhm.
Because if they're like, oh, I don't really care about the cosmetics, I just have trouble swallowing. Well,
Mhm.
sometimes that one session does enough, right?
Right.
You're able to treat that part that you have access to. When it shrinks, the rest of the nodule moves up. Sure, they got a lump in their throat, but they're like, I can swallow. I'm happy. Can we just keep
Right.
an eye on the stuff that's left behind? And so a lot of times those patients are just told, well, it's too big. You can't do RFA because it's too big.
Mhm.
And that's just not really an accurate statement. So, if we circle back to your question of how many surgeries we're avoiding, that is an interesting statistic, but to look into, I just think if you looked at, data from 2018 to 2022, you're going to get a dramatically different, number in terms of how many surgeries are being avoided. I remember when I started doing this, you'd have, 3 or 4 times the number of people who insurance just was like, we're not covering that
Mhm.
compared to the number of cases that you did. And that's becoming less and less and less common now. We still have disagreements with some insurance companies.
Yeah.
And I know you've had some previous podcasts about the reimbursement for it, which I think that, particularly for the Medicare population, is going to be the biggest
Yeah.
prohibitor in this gaining no more traction in the United States. But I think if somebody has a nodule, especially if it's not cancer, I really think it's important that they speak with someone, surgeon, interventional radiologist, endocrinologist, somebody who is at least minimally familiar with the procedure, if not actively doing it themselves.
Absolutely. That is the primary piece of advice we give to patients who want to get an actual physician's opinion on this. Like, am I actually a candidate for this procedure? How can your doctor tell you yes or no, you are not a candidate if they don't actually know about it and do it? They're most likely not going to give you an accurate estimation of true candidacy. And so we always tell patients go to someone who actually does this procedure because that's the only way you're truly going to know. And right now, even 7 years in to these procedures being available here in the US, the non surgical options, we still have a huge amount of unawareness in the medical community so that a patient may not even be told that this is an option if they don't know on their own. And we
Mhm.
have this really interesting population of patients who are so much more motivated than previous generations were to take it upon themselves to educate themselves on their options, to join communities like ours, like Save Your Thyroid, and to go into the doctor's office already knowing about
Mhm.
things to a certain level before they actually talk with the doctor. And I think that's critically important for people to realize that we're still in that stage right now where you may go to the doctor and ask about this and they may not know as much about it as you do. And so the patients in this area are having to take it upon themselves to advocate for themselves and to find the physician that can help them actually really know truly are they a candidate or are they not a candidate for these procedures. So I think that's great you mentioned that. Before we kind of get more into the details, just kind of talking about your philosophy of care at your practice. Tell us, what is your primary mission in your practice as an endocrinologist?
I mean, excellence in everything. I mentioned from, talking to my staff about, granular stuff, how they answer the phone to how we
Mhm.
do scheduling. We have a fast track sort of way we do things for people who have thyroid nodules or interested in RFA. I actually have a standing order for my patients who are pregnant who have thyroid problems. I've joked with my staff that if someone, calls you from the Salt Lake City airport, tells you they're pregnant and have a thyroid problem, just put them on my schedule and
Mm.
we'll figure out their records and everything else, after the fact. But
Wow.
that's part of the reason to do the practice on my own and to strike out on my own, because I can do things like that. I don't
Yeah.
have an administrator or someone else that, it has to go through this way and referrals have to go here and we have to have this information and we have
Mhm.
to do that. So it provides me a lot more flexibility. Same thing with the procedure itself. It's just, excellence in everything we do. I'll have times where we're doing when we're in doing the RFA procedure and there's sort of a little wedge there and I can tell is left behind. And I just tell the patient, if you're doing fine and you're doing okay and everything's going good with the procedure, that I'm basically going for perfection with this particular case. And so I have very, very, very few nodules that are not responding to RFA. I think a little later we're going to talk about some upcoming technologies and other things. And I have some imaging modalities and things to talk about that to help do that. And I have the freedom to do those things. And so it's very linked to your previous statement about, the patients being more educated, knowing more about the procedure than many of the physicians in the community or in their area. Is that to really save people's thyroids and keep people from having unnecessary surgeries. I really think it's going to become more common for individuals to strike out and do this. You'll always have the universities that do it. In my home state, North Carolina, the handful of places that you can have it done are basically at the universities. But, the universities are big, often sometimes government, funded / run institutions. And there's just a certain inherent bureaucracy and inertia in doing that. And so I think really with that sort of new modern patient that's informed and really wants to know what's going on and what's the best for them, I think that you have to have a sort of different kind of practice to do that. In the rare instances that I've had patients who I either just didn't feel RFA was best for them or, would require multiple sessions for a good outcome, have these it's very frequent that these patients are very knowledgeable of it. And so there's a mutual understanding of, should we do A or B or C? And that's more common in the autonomously functioning nodule arena that we talked about before. And so I just think practices have to be more nimble. And then when you sort of focus on it, right? I'm doing thyroid nodule and thyroid disease and thyroid ultrasounds and thyroid biopsies and RFA and, I'm starting to get back into ethanol ablation, that's becoming easier to do now. That's literally all I do every day. And so, you're going to get the cutting edge. This is what I think, and this is what I think is best for this particular patient.
That's excellent. Not to just be parroting what you said about excellence, but having someone who is doing this arena daily is really critically important. And I tell patients all the time, especially if you're going to have surgery, find someone who's doing these all the time. You want that excellence in your surgical care, but it applies to this as well. It's
Absolutely.
so absolutely important that you have someone who really, really knows what they're talking about and what they're doing. So that's incredible. The thing that's so unique about this area of medicine, you're talking about referrals and the path for the patient. It's not traditionally been in the past where the patient strikes out on their own to find what they're looking for. Generally speaking, you go to the primary care, they refer you to the endocrinologist, they refer you to the surgeon, and then you end up with the surgery. And here we're in a situation now where the patient kind of has to sometimes depart from that traditional path to find what they're actually looking for. And in this case, which is RFA for treating a thyroid nodule. So that's why I'm so passionate about helping people find the doctors that are doing this, because, you are trying to be an excellent physician helping these patients. And we have these patients who are looking for that. So my goal is to pull the two of you together and help you find one another. So, and I love what I do.
Well, it's and you're very good at it. And those of
Oh,
us who
thank
do
you.
this and those of us who do this very much appreciate it. And, I think that is one of the reasons too to sort of be independent. Like I said, I can
Hmm.
tell my staff, right, if someone calls and says, I have a nodule, I want RFA, they're just going to tell them to send their information and I'll take a look at it.
Yeah.
And so this, requiring a referral is becoming somewhat antiquated in that
Hmm.
respect. And I still see patients. I had one a couple of weeks ago who had a hemithyroidectomy for an indeterminate nodule, and she didn't even have molecular testing before they did the surgery. And it's right. I mean, I kind of make that face. I mean, you don't in front of the patient, but I kind of make that face as well. I'm thinking to myself, what year is it?
Yeah.
And so you still see it. And I'm not, I have a history of practicing in rural locations. In order to do this, that's not really a possibility very
Mhm.
easily anyway. But to still see that, it's sort of similar to my patient from Boston, that you just really, you kind of ask the patient and keep your professional sort of poker face. So did they do molecular testing before you had? Oh
Right.
no, they just told me that I need to go straight to surgery.
Wow.
And so it still happens in 2026. Yeah.
Yeah. Well, for the viewers watching this podcast, I am working on some podcasts on molecular testing. So stay
Okay.
tuned for that.
All right. Excellent.
That is another area that we need a lot more education on for patients. So I'm glad you mentioned that. Well, we've talked about RFA, kind of just like that you're doing it and that patients want it and that we can treat hot nodules with it. Can you, for the new viewers who may not know what in the world we're talking about, kind of just give us a brief overview summary of why someone would even want to have RFA? What is it for?
Yeah, so RFA, radiofrequency ablation, is one of the non-surgical techniques. It's one of the thermal ablation techniques for thyroid nodules. It has multiple applications, most commonly for benign nodules, either nodules that are making thyroid hormone, which we referred to a few times as hot nodules, or nodules that are not making thyroid hormone, which is probably the most common application. It also has been used in cases for parathyroid disease, thyroid cancer, lymph nodes and thyroid cancer. I'm actually published in one of the first case series of enlarged malignant lymph nodes for thyroid cancer. And so it's not just for thyroid nodules, but the main goal or the main reason for doing it is what you're trying to do is protect the normal, healthy thyroid tissue that's not causing any issues. So if it's a nodule that you don't like how it looks cosmetically, or if it's a nodule that's got problems swallowing, or if it's a nodule that's making your thyroid overactive, the normal surrounding thyroid tissue is an innocent bystander. And the primary issue with surgery is the extreme exception that you can't just remove the nodule. So it has to do with the vascularity of the gland. And so, generally speaking, in most instances, if you're going to have surgery for thyroid nodule, they have to remove at least half of the gland. And so you're removing a lot of healthy thyroid tissue. You're removing a lot of tissue that's functioning normally. And if you take a patient, depending on their age and what their thyroid levels look like before surgery, anywhere from 20 to 30, sometimes higher than that, percentage of patients who have a non-urgent surgery for a not cancer, those patients end up on thyroid hormone for the rest of their life. And the real concerning part on that is a good 1 in 5 people who have their thyroid gland removed and end up on thyroid hormone don't feel well afterwards.
Yeah.
And I'm sure your viewers know, either themselves or a friend or a family member who are kicking themselves. Why did I have surgery? I don't have cancer. Now I have to take this medicine for the rest of my life. I don't feel good. My doctor tells me my levels are normal. And it's a known thing in the medical literature. And so if you can have a treatment that fixes the specific problem without doing anything or damaging the normal surrounding thyroid tissue, why wouldn't you, basically, assuming that it's, that you're a candidate for it and it's safe for you to have it done. There are other benefits. It's cheaper. That is a little bit of a sticky situation that we've talked about before with reimbursement, but it is cheaper. It doesn't require hospitalization. You don't have general anesthesia. Generally speaking, I do my procedure really now in 2026 with local. I haven't had a case that I've done with conscious sedation in a while. It can be done under conscious sedation. Many practitioners who do them under conscious sedation. There's no scar, and I think that is, I do not treat that as a vain thing. If you look like you have this sort of serial killer slasher scar on your neck, that is not necessarily a nice thing to have. Now a good surgeon can hide it and make it not look so bad, but not everyone heals great from scars, and it's still there. In my years of doing this, I've had 0 vocal cord nerve injuries, and I haven't had any major complications at all. With a hemithyroidectomy, half the gland in the hands of a good surgeon, the rates of complication are very low. But if you talk to many of them, not necessarily only doing it for 5 years, their complication rate is not 0. And so arguably a lower complication rate. My surgical colleagues would probably argue with me about that, but definitely cheaper, no scar, no hospitalization. And, patients are generally, I think, very impressed with how minimal the recovery is. Usually when the local anesthesia wears off around the site is the most common time that people notice some discomfort. And there's always some pressure and you feel like there's a lump, but it is generally speaking not a painful procedure. So much so that I typically give my folks, a couple Valiums. I know some of my colleagues don't give anything. I have to admit, I wouldn't do that if it was me. So I don't usually suggest that. I have had a few patients who did not want to take anything just because don't like how they feel with medications or have
Yeah.
had bad reactions to them. But you're definitely more leaning on the side of doing nothing as opposed to general anesthesia.
Yeah, just something to kinda help you relax while you're sitting
Yeah.
there for the time that they're doing the procedure is really nice. I think that the vast majority of patients appreciate that, and I think the doctors do too, just so that it's a more calm and relaxed situation for them, so and of course, you're not doing these in a hospital, right? You're doing them right in
Yeah.
the clinic.
Yep. So they're all done in the office. So
Mhm.
it is an outpatient procedure, and it's not does not require an outpatient surgical center. I basically just set up my largest room in my office for doing the procedure. So yeah, I'm glad you brought up that point because that is an excellent.
Well, and it's just so nice when you're the patient going to have this done. I had 2 RFAs for the people who are not familiar with my history. I have a whole playlist on my RFA experience. Started back in 2019. I had a second procedure in 2020. I had those done in a hospital and I had a fantastic experience, but it was a very overwhelming, anxiety provoking scenario to kind of walk into that hospital, navigate the hospital, go through all of it's in a OR, scenario where you gown up. Everything's very, very much like surgery, except for that you don't have to stay overnight and you're not put to sleep. I've observed probably close to 20 procedures now in clinics across the country. And the procedures done in the clinics are just so much more calm. The patients don't seem as, anxious about it. It's kind of a step up from going into the clinic for your biopsy, really, because you're going in, you're laying in the chair. It's just a little bit more than that, you know?
Yeah.
So I think it's fantastic that you can do this in a clinic.
Yeah, I actually sometimes joke when patients kind of want an idea of what it's like. I tell them it's a little bit like what your thyroid biopsy was like if you combine that with my mom's sewing machine, right? Because you're literally just using the electrode to see, you're using the transducer, the ultrasound to see where the electrode is. And then I literally have a foot pedal, like my
Mhm.
mom's old sewing machine that you do. And, I think another strength of being a singularly focused practice in a multi-specialty group, outside of folks who come and see me out of state, they know my front desk person, they know my
Yeah.
MA, they know my staff, they saw me when they had their initial evaluation, they saw me when they had their biopsy, they saw the same people when we did, discuss the procedure and sort of did our RFA planning. And so, oftentimes by the time you're ready to do that, I mean, you practically know everyone by first name that works in the office. And so that is a very, very different experience. I have not done any cases in the hospital. That has not been a thing for some time in our area. It has not been on my radar. But that would be a very, very I don't even like going to the hospital, period, even when
Right.
I'm not a patient. So and so, yeah, it's a much, much, much better experience, I think, when it can be done.
Well, we've talked about RFA now, but you do all things thyroid. We kind of alluded to that in the beginning. So tell us about all of the other things that you're doing in your clinic for thyroid patients as far as diagnostic, treatments. What are you excited about?
Yeah, so right, RFA is a large part of the practice, obviously. I did mention I'm getting back into ethanol ablation, and so for your viewers who are not familiar, that RFA is highly effective for solid nodules.
Right.
When you have very large cysts, the major difference between a cyst and a solid nodule is the cyst is fluid filled. I really sort of think of them like a water balloon. RFA is not effective in those situations. And in those instances, when you drain them, if you just drain the cystic fluid, the wall of cells that are making the fluid, nothing happens to those. And so the recurrence rate of a cyst is in the order of 90 to 95%.
Mhm.
And so if you drain a little bit of fluid out of it and then inject it with medical grade ethanol, it will cause the cyst to shrivel down because it kills the cells that are making the liquid. That used to be difficult to do because it was hard to secure the ethanol for the procedure. But as compounding pharmacies have expanded around the country, I found some pharmacies that can give me some medical grade ethanol at a
That's
reasonable
great.
price. And so getting it commercially otherwise is very cost prohibitive.
Yeah.
Obviously, do my own ultrasounds and biopsies. You have an upcoming podcast with respect to molecular testing.
Mm.
That is what we do.
Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation.
I'm actually one of the few endocrinologists that I hold a materials license for giving radioactive iodine. So that's going to be a heavy lift, but I'm looking forward to probably in the next year, more likely 2, to have my own hot lab. And when I have that, basically anything that does not involve surgery, I'm going to be able to do. And then I've got great surgeons I know down the hall if you do need surgery. There's some emerging imaging technologies that I'm looking into. There's some 3D ultrasound imaging that can be done that sort of gives you a better view of how the nodule, sits within the thyroid or within the neck. There's been several papers over the last several years that have shown elastography. So elastography is an ultrasound technique where it tells you how stiff the nodule is. The holy grail or the way to do it would be for me to see someone that have a nodule and go, that looks like it's a pretty good candidate nodule, but I'm a little more concerned that this may be one that does not, respond well to RFA. And there's good emerging data that shows the stiffer a nodule is, the more resistant it is to the treatment. I think that will be important for treatment planning. I would plan for a longer session. I would plan for a higher amount of energy being delivered, as opposed to if you have a very soft nodule on elastography, those tend to respond very well to the thermal procedures. We've always sort of known that, but in a way to sort of quantify that, which elastography would let you do. And there's several studies now that have shown that that can be helpful. So I plan on implementing that, the latest and greatest ultrasound technologies with respect to the planning. That and the Newt Med are really the next big steps for me. But sticking thyroid focused, parathyroid focused, happy to have conversations with people about parathyroid and RFA, as well as thyroid cancer and RFA. Not everyone who does this procedure will take on those kinds of cases, but just basically to stay at the cutting edge. I am looking to get some experience with the nano pulse wave.
Okay.
I'm not sure where that's going to go. The electrode for it is very expensive. And there's some rumbling about folks doing it more in surgery centers, which I think is going to make it less accessible. And I think that's one of the things with what happened with the reimbursement for RFA is really going to hurt that technique. While it's a different code to the government and it is a different procedure, it is a different technique. It is a non-thermal, meaning it's not heat related in terms of its, super short pulses of electricity that disrupt the cell structure and causes them to die. Now, the idea behind the technology is that it'll be safer to keep you from damaging nearby structures. I think most of us who've been doing RFA for a long time are generally not concerned with that. And it looks like the speed of the improvement of the shrinkage of the nodules is faster, but at the end of the day, I'm not sure how important that is. But I think there's some concern that will be cost prohibitive. But I am starting to dabble in that a little bit. It's basically the same technique and same procedure. So if you could do RFA, you could do the nanopulse. Probably a little more in detail than necessary for the podcast. But primarily the goal right now is to just have the best thyroid and parathyroid care, in this part of the country, if not the whole country.
Awesome. And for any viewers who are interested in learning more about Dr. Orozco's experience with the nuclear medicine stuff, treating hot nodules with radioactive iodine, we actually did an extended conversation on that topic previously. I'll link that in the description below. Very interesting. I learned a lot in that conversation that I did not know about radioactive iodine. So very interesting podcast episode.
Yeah, it is a topic that's not discussed as much. I think the large benign nodules and the thyroid cancer get a lot of the discussion with respect to non-surgical techniques. And it is, while not as common, it is another condition that is an important topic that you don't necessarily need to have surgery.
Definitely. You mentioned that you have some patients that are coming in from outside of the area. So,
Mhm.
um, and that you're already training your staff how to address these out of town patients. So, for anyone who's watching this who's thinking, I want to go see this doctor, how would they get that type of appointment set up to come see you?
Yeah, so the easiest way would be to just email, and it can literally just be an opening email of, I have a thyroid nodule, I'm interested in RFA. Is it to referrals at thyroidutah.com. That is
Mhm.
really the easiest way to do it. That email is checked on a regular basis, and my staff will just reach out to you and, sort of find out where you are in that journey. Have you had a biopsy? What were the results of that biopsy? And then, sort of depending on that, receiving that preliminary information, I will review all of it. In some states, doing a telehealth consult can be a challenge.
Mhm.
Unfortunately, I can get on my soapbox about that along with reimbursement for RFA.
Mhm.
This is not the era of the Pony Express. I
Right.
mentioned that RFA is not available in some states. And so this whole concept that I can't do a consult in another state without a medical license is ridiculous. You can work around that. I just typically, in that case, call the patients and have a conversation with them about what I think about their case is. If it's one that, I feel requires a second biopsy, for them to have that arranged locally. That sometimes can be more of a challenge than I wish. And then, one of the things I have with the freedom of having my own practice is that I can have folks come in from out of state, meet me on a Friday, go over all their stuff, talk about the procedure. This is obviously after some vetting that they're a candidate for the procedure. And
Mhm.
then I'm run my own thing. So if, we want to do your case on a Saturday, I can do your case on a Saturday. And
Wow.
then, you're here for the weekend and then you fly back to wherever,
Mhm.
on Monday. And so again, the small practice provides a lot of flexibility with respect to that. And I think that goes to our earlier discussion about, the 2026 patient who doesn't want to, either can't or doesn't want to go through their primary care doctor,
Mhm.
doesn't want to go to an institution where a referral is required. It's as easy as sending an email
Mhm.
to referrals at thyroidutah.com.
It's kind of empowering when you really think about it. I could call you up and say, Doctor, I want to see you about this nodule. And that's what starts it all. It's not
Mhm.
necessary to go through the primary care referral pattern anymore. But insurance can sometimes be a hurdle in that regard, unfortunately. And so let's talk about insurance for a moment. Talk about,
My favorite topic.
my gosh, it is my least favorite
Yeah, yeah, that
topic,
was sarcasm, and your viewers
right?
from Ohio, if your viewers from Ohio will know exactly what I'm talking about. Yeah.
I absolutely, if you want to get me on my soapbox, we talk about insurance problems, but we're not going to talk about that right now. We're going to talk about what insurances are you accepting major plans and what's the best way for patients to kind of get through that whole scenario of dealing with insurance regarding to the
So,
RFA
so
specifically.
yeah, so I do take major insurances,
Mhm.
especially here out west.
Mhm.
Blue Cross Blue Shield, even though it varies by state,
Right.
generally speaking, is totally agreeable. Exceptions to that rule for nuke medicine and RFA tend to be New York and New Jersey. But we do have, integrated, coordinator and process person who helps me with, getting it with respect to other people's insurance companies. It's much better now, as you know, than it was years ago.
Right. Right.
It's still sometimes I joke, I feel like it's talking to the IRS.
Mhm.
I had one insurance here in Utah, two of the cases sailed right through.
Mhm.
One of them, same insurance. Oh, that's experimental.
Oh yeah.
And yeah, and then the other
Hear
one,
it all
same
the time.
insurance. Yeah, the other one, same insurance, and says, oh, we don't cover that. I'm like, here, let me show you the case that you did cover,
Mhm.
last month. And so, of course, I have a form letter appeal, for that sort of thing. And so we help patients with that,
Mhm.
every step of the way. I do also, of course, offer it on a cash pay basis, which we haven't had to do that very frequently anymore. And
But a
some of
lot of
it is
people don't know that.
right.
I still try to make that point aware, make patients aware of that point is that this is not, it's not required that your insurance cover it. It can be
Mhm.
your cash pay.
Yes, it absolutely can, and it's reasonably affordable to do that. I mean,
Mhm.
the equipment for doing it is not inexpensive, and the staff training, and of course my time to do it.
Mhm.
But absolutely, I still have cases that I do that are cash pay. I
Yeah.
would say it is more frequently when it's out of staters, admittedly. I think Utah is, very forward thinking with respect to that. That's one of the reasons why I started doing it here in the first place, is
Yeah.
because it was one of the easier places to do it with insurance. But yes, it is most certainly an option to do that. And I would think that most folks who do that, especially, I'm going to harp on the small specialty single focus group, we can help you with that. Now
Mhm.
if you're going to talk to the big university with all the red tape, that may be a different question or a different story. But I think it can be accessible for everyone if it's something that they want to do and if they're a candidate for the procedure.
And if you are watching this and you have been told by your insurance company that RFA is considered investigational, that is a lie. It is not
That's a lie.
investigational.
That's a lie.
The procedure is cleared by the FDA,
Yep.
and CMS created a code for billing insurances and Medicare January 1st of 2025. It went into effect. So that
Yep.
is a lie.
That is a
So,
lie.
and you
Yes.
can point that out confidently to whoever you're
Yes.
discussing that with on the phone with your insurance company, just to make it
Absolutely.
perfectly clear.
Yes, we certainly appreciate it when the patients are allies on our side, when the
Yeah.
insurance company's getting it from both sides. So,
Mm.
yeah.
We've got to get them to stop saying that because it's just not true. So, well, on a personal note, what are you most looking forward to in this next phase of your career? Because this is kind of a new frontier
Yeah,
for
I
you.
mean, I'm kinda living the dream right now. I mean, as far back as training, my office manager told me that I was probably gonna have to have my own practice because I like things done a certain way. Right now, I'm just living in the dream. I mean, we've separated now, formally separated this practice from the larger multi-specialty arm just this January 1st. So, I'm 2.5 months into this. I couldn't be happier. I'm having the freedom to make the decisions that I want to make, both from an entrepreneurial slash business perspective, as much as just feeling very freed to provide the best possible care for patients. It really becomes, if I could just make it with just me and the patient without the insurance company involved, it would
Right.
be nirvana.
Yeah.
But it is now my practice, my operating procedures, my way of doing things to really be able to provide the best experience for the patient. And so it's just the two of us, and then unfortunately the insurance company. I'm looking forward to the ability to grow. Right now the primary location is in Provo, and so that's a good. There is a little airport in Provo, so I
Hmm.
do remind my out-of-state patients from time to time that you can fly into Provo. It is a little regional airport and will require a connector, but it is actually sometimes cheaper.
Hmm.
But that puts me about an hour south of Salt Lake City. I have a satellite office that I'm in right now, which is in Lehigh, which is about halfway
Hmm.
between Provo and Salt Lake City. Salt Lake City would be a bit of a commute for me. I don't know that I will go ever that far north, but there's this area of Utah is expanding dramatically, and so I probably will have a second satellite location at some point in time. So I'm looking forward to growing that, as part of my offering and part of my practice.
Excellent. I think that anyone who wants to travel somewhere might be interested in Provo because isn't that like a primary destination for skiing and
Oh yes,
hiking and
absolutely. So BYU, the university's there. So if you
yeah.
want, top notch college football and college sports, that's the place to be. The Sundance Film Festival, not far down the road, although that is moving to Colorado shortly.
Mhm.
And then, yeah, we have world class skiing here. Olympics coming in 2034.
Mhm.
It is, where this is not a slouch place to come visit me to do that. I kind of point that out for my folks if we're talking about a weekend procedure,
Mhm.
because after your procedure, other than I don't want you to drive for about 24 hours, you can pretty much do whatever you want.
Isn't that wonderful? I see patients all the time in our community say, "Well, and I was hungry, so we went out to dinner,
Mhm.
and we went sightseeing and we planned a little weekend trip around it." With that in mind, I mean, we're thinking about intervening in a minimal way to help patients. Where do you see this field of interventional endocrinology going in the next 5 years? I think it's kind of exploding.
It is exploding. I think the big one will be as the insurance companies get used
Yeah.
to the procedure.
Yeah.
And as we have more practitioners who are doing it, it becomes more widespread that we're going to see a lot less thyroid surgeries. I do think once the insurance companies understand that the cost savings involved. I sometimes joke with my patients, they're not a number to me, but they are to their insurance company. That, I had a similar thing with molecular testing, which will probably be touched on in one of your upcoming podcasts. That, I actually ran the numbers with someone from United Healthcare like
Hmm.
15 years ago and explained to them the scenarios where they would actually be paying less money for the same number of patients if they just paid for molecular testing.
Yeah.
And I think RFA is the same.
Mhm.
Surgery is going to cost you 4 times as much as having is, and
Right.
then if you get in the realm of normal disrupted thyroid tissue, and then you're on thyroid hormone, and you have lifelong visits with the doctor because you're on thyroid medicine. The potential for cost savings is insanely high.
Yeah.
And it's one of those ones where you really have to wonder, what is the insurance company? Like, I don't get it,
I
right?
know.
Because
I
I
know.
understand that you may not care what's best for the patient while I do, but at the same time, I'm going to save you a buck in the process as well.
Right.
And so I think it's just going to explode. I'm excited to see sort of more data on the additional applications. I think most of us hesitate on some of the parathyroid cases based on the location,
Hmm.
just because that nerve that goes to
Right.
the voice box is right there, and you're just like, yeah, I'm not so sure about that one. As opposed to other ones you look at and go, yeah, that one I can take care of that one. So I think more data on that. I think the cancer data, particularly I think the data for lymph node metastases is super encouraging. That we have good data, way less invasive. Surgeons don't like to do a second surgery in the neck when there's recurrent thyroid cancer.
Right.
And so, and there's a reason why they don't want to do that in terms of complications. And so I think that's an avenue that will become greatly expanded in the future. And then similarly, also with the thyroid cancer, I think that we're starting to sort of expand a little bit the staging and degree and size of thyroid cancer that as we get more data, that we're willing to consider RFA as a procedure.
Hmm.
There are the new technology coming out. There's won't be necessarily in my realm, but it's certainly on the radar. There's a place there's a university in California. It's escaping me at the moment. The place where they actually do an arterial embolization
Hmm.
of the thyroid itself. And so if
Hmm.
you have that massive giant, thing where I look at you and go, sure, I can do RFA, but we're going to do 3-4 sessions, and you know, it's I'm going to be basically killing the same amount of tissue as the surgeon. So, if you don't care about a scar, think about surgery. If
Hmm.
you can have that radiology guided technique to then basically, kill off half the thyroid gland without having surgery, that's going to become, I think that there's nowhere but the stars for that, I think, in terms of those specific cases. Now, that's
Hmm.
obviously not as common in the United States as the thyroid nodule and RFA type things, but surgery is going to become less and less and less and less important in the thyroid world. My dad was a general surgeon, and he used to joke, he called it physician guided trauma.
Hmm.
um, and so I just think we're, like I said, I don't think we're in our infancy yet, but I don't think we're adolescents yet either. We still get
Hmm.
too much pushback from insurance companies. It's still not as
Hmm.
widely accepted in the community it is. And I'm a little sad, to be honest with you, when I see folks, I see that patient who had half their thyroid gland removed and didn't even have molecular testing. And you're just like,
I know.
and she's not in my office because she's fine, right? I'm not seeing her in the post-surgical setting as an endocrinologist because everything went well with her surgery. And so it's I think it's an exciting time. It's great to be at the ground floor and the frontier of really what's changing the landscape of medicine in the thyroid.
So exciting. Yeah. And just as a side note, what you mentioned about the arterial embolization,
Mhm.
that's actually more widely available than you may realize.
I didn't know him. Yeah.
I've done a few podcasts on that as well,
Mhm.
and, yeah, there's I wanna say maybe a dozen centers across the US that are doing it, and they're finding that they can address all of that excessive goiter tissue, growing down into the chest and whatnot, while still leaving the main part of the thyroid alone and functioning. It's really great. Last week, I released an episode with a patient who had it done, who his goiter was growing all the way down to his heart, and he would have had to have his chest cracked open, and, that's just not something anyone wants to sign up for.
No, it's not. And that I've had 2 cases in the last little bit that I basically deemed not candidates for RFA for that
Yeah,
reason. It's just
yeah.
you have so much tissue that's down in the chest
Mhm.
that it's what I can do is just not gonna
Right.
make you better.
There's a
Um,
use case for
and so,
something like that in that case, so it's exciting. So, okay, so we're coming towards the end of the episode, but I wanna do a lightning round with you. How do you feel about that?
okay.
Because, I think that's kind of a fun way for people to kinda get to know you and get quick answers to certain questions. So, what's the best part of the day? What's the most rewarding moment for you? Is it the consultation or the follow-up or the results?
I have to say, I definitely like the result. When
Mhm,
you have that, you've done it, you've done the procedure, it's gone well, they've got that 80, 90% reduction in their nodule. It's real close to a tie, though. I mentioned that patient earlier where it was clearly a hot nodule, and you're just sort of going through the records before you meet them, and you're like, please tell me you haven't had surgery, right? Please tell me there's no surgical pathology included in these
mhm,
records. And to really just see patients understand and realize, especially those who've done their own homework, that they're
mhm,
talking to someone who knows about the procedure and that they're a good candidate for it. And just it's palpable. It's in and that is a new thing, I think, in the thyroid world, right?
mhm.
Because usually it's, oh well, we're gonna go after surgery and you're gonna be okay and everything
Yeah.
it's just a completely different stance in my 20-year career when you have someone with, that knowledge and you're like, yes, you're in the right place. And yes, I think
Mhm,
we can definitely make this better. And the unique one, and we're kind of talking about it multiple times, even though we've already done a podcast on it, but that patient who they understand not only are you not going to require thyroid hormone after the procedure, but I'm actually going to stop your medication that you're currently taking the day after the day of the procedure. Like take it the
mhm,
morning you come see me, and then don't take it the next day. And so there's nothing more fun for me, and that's been the case even when I did more general endocrinology over a decade ago. When you can take someone's medication away and they don't need it anymore, there
mhm.
ain't a whole lot in my office that makes me smile more than that, than when I can stop somebody's medicine when they don't have to take it anymore.
That's awesome. All right, let's bust a myth. If you could instantly clear up one misconception about thyroid nodules for every patient, what would it be?
Surgery is not your only choice. You can have something else can be done.
All right. Beyond RFA, what is one piece of medical tech or research currently on your radar that gets you most excited for the future? We kind of already covered that, but if you want to, is there anything else you
Yeah,
want to
it's
throw out there?
it's the I think the emerging imaging technologies are going to be help us some to better risk stratify folks who
Mm-hmm.
we think will do well and not do well with RFA. I'm
Mm-hmm.
running way less than 10%, probably less than 5% of my folks who don't have a good response.
Mm-hmm.
The elastography that we touched upon, there's some data for that for it differentiating even between thyroid cancer and a benign thyroid nodule. And so I do think the imaging technologies, I think you can merge that with your biopsies and your ultrasound characterization of a nodule to sort of help you guide, how difficult is this procedure going to be? How much energy am I going to deliver? I think I can better give the patient a more informed sort of what do I think is going to happen with their specific nodule. And then
Mm-hmm.
on a personal note, as we mentioned, it's not a new technology, but I'm very much looking forward to doing my own radioiodine in the office. Outside of surgery and specialty imaging, I'll be able to pretty much do everything.
Mm-hmm. Yeah, keep those patients there so that they're with someone that they know and are familiar and comfortable with. That's awesome. All right. Well, what about for the hesitant patient? Any patient who's listening to this podcast who's been told that surgery is their only option, but they feel in their gut that there's another way. What's your one sentence piece of advice for them?
Find someone who knows something about non-surgical techniques for thyroid nodules. It can be me in the state of Utah or someone who's near you. Referrals at thyroidutah.com. Most of the folks who do this are very open and understand the hesitation. I think if you are in an area where it's not available and you're like, is this a random TikTok video that, one weird trick ad on the internet, or is this the real thing? We
Mhm.
thank you for getting the word out there that that is not the case. But most of us who are doing this are very excited to do it. And every time we can keep someone from having surgery, it makes us very happy. It makes the patient very happy. And I think it's like you said, the paradigm has changed a little bit. You just reach
Mhm.
out to someone, find someone on the internet, take a look at, Jen's blog and material and who she talks to, who's close to you, who do you think, you can have a good conversation with about this case, how do they handle it if you're out of state? But just reach out to someone. I can't you can't undo surgery, right? In
Right.
the handful of cases where I've had, either RFAs that did not get the outcome we wanted, or, I've had ones before. I've had several before, many before, where I've been, I've had a second opinion. Someone else did their case. What do you think about, my nodule? Should we redo it? Should I go have surgery? The likelihood of you having a complication from RFA is very, very, very low.
Hmm.
And if it doesn't work, the more common scenario is, again, the one we talked about with hot nodules. So if you have a big nodule that I don't think is a great candidate for RFA, well, guess what? If the RFA doesn't work, you've done that, you've done everything that you can that's not surgery, then unfortunately you may have to go have surgery. But it really should be really far down on the list of priorities of what you want to do outside
Absolutely.
of a diagnosis of malignancy that clearly requires surgery.
Hmm.
Explore the other options.
Absolutely. I'm going to add this one point in because I think it's so crucially important. Unfortunately, so many patients, when they go to a surgeon for a surgical consult, and this is not to knock surgery, this is just the nature of how the consults tend to go. They get their consult, and then at the end of the consult, they say, let's put you on the schedule.
Mhm.
And the patient doesn't understand that that's a matter of convenience for the practice and the physician and their schedule because they're busy, and not a matter of urgency on the part of your situation most of the time. There would be cases where that may be the case, but 9 times out of 10, I would say your situation is very likely not that urgent that it has to be dealt with right then.
So, and it's always been my practice style to work very closely with surgeons.
Hmm.
So when I've been in different parts of the country working, I usually find one or two that I actually often just call up and kind of bounce how ideas of on how I like to do things and how I want to do things. And even some of those I have had to educate. Don't do that. Don't just put them on the schedule. And it's not necessarily related to RFA or alternative things, but I occasionally get I see a patient in this new consult for thyroid cancer, and they're on
Hmm.
the schedule in 2 weeks. Well,
Hmm.
you're not going to be ready for surgery in 2 weeks, because if you have a lymph node that I want to biopsy to make sure that you don't have metastatic spread, or if you
Exactly.
have something else going on. But and I bring up the thyroid cancer specifically, even the surgical cases for thyroid cancer, that even in that setting, it is not an emergency.
Hmm.
Most
Right.
95 times out of 100 for
Right.
them to be on the schedule in 2 weeks. And so if you take patients, which is more what we're talking about, hot nodules, large benign nodules, parathyroid surgery, there's no urgency in that at all. In the pre-RFA days, when I would have patients where we were talking about, big nodules and I'm having trouble swallowing, if I took folks who were, 62 or so, I would just tell them wait 3 years and let the government pay for it. I mean, so you're kind of on that time frame,
Yeah.
not let's talk to my surgical coordinator and I want you on the schedule in 2 weeks.
Right.
And so, yeah, that is a very, very good point, that this is, by definition, particularly for the non-surgical techniques, this is not an urgent procedure.
Right.
Because if it was an urgent procedure, whatever your issue is, you're not a candidate for a non-surgical procedure. And
Mhm.
so, absolutely. And I think that you're correct. It is a matter of convenience. And some of the
Mhm.
surgeons I've worked with have required a little more a little more input from me to not do that.
Yeah. Yeah, I will just add this one little last plug is I'm doing consults now for patients. So like
Mhm.
navigation consults, not giving medical advice and not making recommendations, just helping navigate uncharted territory for these patients
Sure.
who don't know which direction to go in. And they often come to me and say, "Well, I have surgery scheduled in a month." And I have to figure this out now. And once I hear their scenario, like what's going on with them, I have had literally only one patient where I was like, "Okay, I think you might actually need to deal with this urgently." The rest
Mhm.
of they're dealing with something that's not in a very urgent situation where they have time to weigh out all their options, to do their research, and to feel comfortable with whatever their decision is so that they're making that decision based on facts, not based on fear and emotions. Because when you make a decision, knee jerk reaction decision, you're most likely going to have some regrets. So let's not get into a
Absolutely.
regretful situation.
Absolutely. And I think the importance of with talking to someone who understands all of the options is very important. I've had more than one case, even in the last couple years, of patients who, when you talk to them about the RFA and what the procedure is and what it's involved and what are the advantages of it and all this, and you go through it meticulously, and they kind of look at you and go, so you're not taking out the nodule? No, I'm not removing anything, right?
Right.
I'm shrinking it, and it's going to decrease in size by, preferably 80, 90%. The literature says greater than 50 is a success. If it's less than 70, I'm pretty disappointed. But, at the end of the day, I'm not removing anything. And
Right.
I will run across a patient from time to time who they just do not like that idea.
Right.
Is it going to go back in 20 years? How do we
Right.
know it's not going to turn into cancer? Well, the literature shows that that's not going to happen. It could go back over 20 years, obviously. And at the end of the day, they don't want RFA because they want it gone. And for that particular patient, having it removed to them is more important than all the benefits that there are for RFA. The issue is that if you have, someone who's not experienced in a specific thyroidologist, and this is what they do,
Right.
the knowledge of complications from surgery and what you're going to do is going to be a little different if you see more general endocrinologists, just like I'm not going to be as good at running insulin pumps as they are, even though I'm a general endocrinologist by training. But having that knowledge base of what surgery is going to be like and what RFA does, so that goes the other way. To your point, if you're talking to a surgeon who has no experience with RFA, hasn't had a case that's been done before or knows very little bit about the procedure, how can they give you have an educated conversation with you at the professional level of who's a good candidate, who's not a good candidate, what's to expect, and is this the right procedure for you? And so, each individual case in person really needs to be treated like an individual case in person. I know it sounds almost dumb when you say that way, but it is really true. And I think seeing someone who has experience in this, I think that's one thing to sort of touch on, especially for folks who don't have it in their area, right? If you're going to get on a plane and it's going to be to, the one place in the nearby state that does it, and the guy there or lady has done half a dozen cases, if you're already getting on a plane, find somewhere that does a lot of them. Because that experience will matter. I've had several cases where just from doing it for a while and doing exclusively thyroid disease for a decade, and as we talked about, doing this all day and every day, I had a patient who had 2 benign biopsies by molecular testing. So I will do RFA in nodules that require molecular testing. And so for your viewers, those are nodules that the initial cytology comes back benign, and then we run it for some particular, genetic molecular defects that are associated with thyroid cancer. She had 2 benign biopsies through molecular testing. My professional preference is I do them through 2 different companies because the algorithms are a little bit different. And, she had a personal history of 2 previous types of cancer personally. And I sort of just looked at the nodule and I said, on paper, this really looks like a case that you could do RFA, right? It's a good size. It's in a good location. I think we'll get it. We can get a good outcome on it. I was not doing elastography all the time. But I told her, I said, I just don't like how it looks. I'm just, been doing this for a while. I just don't like how it looks. And I said, so, I would think about doing it. I'm really hesitating on it. But if you want my honest opinion, I really think you should go and have surgery. She had thyroid cancer. So she had a very rare subtype aggressive kind of papillary thyroid cancer.
Oh, wow.
Called oncocytic thyroid cancer. And so had we not had that dialogue and had that conversation, if you just checked the boxes, do benign biopsies, good location, no contraindications, great candidate, her case would have been very, very, very different. And so even though it's been around in the United States now for, we're going on 8 years, and it's been available in other countries and for, 20 plus.
Right.
Which is a whole other conversation about the United States. I can't stress enough as it becomes more widely available that how often they do it matters. It really, truly does.
Absolutely. Well, any final thoughts, Dr. O, about the Thyroid Institute of Utah, your legacy? Any final thoughts you want to leave behind with the viewers as we sign off?
I'm going to make this practice the best thyroid parathyroid place, certainly at least in this part of the country. I want more people that fly in to see me from Chicago because they want me to do their RFA. So just to make it from start to finish, from the first time you reach out to the office to, us being super happy, months after your RFA procedure and everything is just going, banging and fantastic. I just want it to be the best experience, and I want as few people as possible have unnecessary thyroid surgeries.
Well, I don't think there's any better way to close this out. Thank you, Dr. Evans.
Thank you very much. Thanks for having me again.
That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.